Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 500 of our pharmacotherapy series, which majors in anemias. The next question applies to patient BHP in the previous part of this pharmacotherapy series. What are the goals of iron therapy? How long should BHP be treated? How should BHP be monitored? The goals of iron therapy are to normalize the hemoglobin and hematocrit concentrations and to replete iron stores. Initially, if the doses of iron are adequate, the reticulocyte count will begin to increase by the 3rd to 4th day and peak by the 7th to 10th day of therapy. By the end of the 2nd week of iron therapy, the reticulocyte count will fall back to normal. The hemoglobin response is a convenient index to monitor in outpatients. Hematologic response is usually seen in 2 to 3 weeks with a 1 to 2 grams per deciliter increase in hemoglobin and a 6% increase in the hematocrit. BHP's anemia can be expected to resolve in 1 to 2 months. However, iron therapy should be continued for 3 to 6 months after the hemoglobin is normalized to replete iron stores. Therapy duration is related to the absorption pattern of iron, with more iron being absorbed during the first month of therapy. Because iron stores are repleted, less is absorbed. My next question to you reads: what information should be provided to BHP when dispensing oral iron? Can be done if she experiences intolerable gastrointestinal symptoms, e.g., nausea, or epigastric pain. Iron should be dispensed in a childproof container, and BHP should be counseled to store it in a safe place, inaccessible to her young children. Accidental ingestion of oral iron can cause serious consequences in small children. BHP should be told that oral iron therapy produces dark stools. She should try to take her iron on an empty stomach, because food, especially dairy products, decreases the absorption by up to 50%. Gastric side effects, which occur in 5% to 20% of patients, include nausea, epigastric pain, constipation, abdominal cramps, and diarrhea. Constipation does not appear to be dose-related, but side effects, e.g., nausea and epigastric pain, occur more frequently because the quantity of soluble elemental iron in contact with the stomach and duodenum increases. To minimize gastric intolerance, oral iron therapy can be initiated with a single tablet of ferrous sulfate 325 mg per day and increased by increments of 1 tablet per day every 2 to 3 days until the full therapeutic dose of 325 mg 3 times daily can be administered. BHP also should be educated about potential drug interactions that can occur with iron therapy. Currently, she is taking a proton pump inhibitor, which is thought to inhibit serum iron absorption by increasing the pH of the stomach and decreasing the solubility of ferrous salts. In addition, antacids can increase stomach pH, and certain anions, such as carbonate and hydroxide, also are thought to form insoluble complexes when combined with iron. BHP is also taking minocycline for the treatment of acne. Because the absorptions of both iron and minocycline are decreased when administered concomitantly, the minocycline should be taken at least 2 hours apart. My next question to you reads: when would parenteral iron therapy be indicated for BHP? Several indications exist for parenteral iron administration. Causes of oral therapy failure can include non-adherence, misdiagnosis, inflammatory conditions, malabsorption, e.g., atrophic gastritis, radiation enteritis, gastric bypass, and celiac disease. The need for rapid iron repletion, and continuing blood loss equal to or greater than the rate of RBC production. Besides failure to respond to oral therapy, other indications for parenteral iron administration include intolerance to oral therapy, required antacid therapy, or significant blood loss in patients refusing transfusion. In BHP's case, intolerance, continued blood loss, long-term antacid therapy, and malabsorption may be potential indications for use and, if documented, she would be a candidate for injectable iron. The next question reads: what is the preferred formulation of parenteral iron administration? Iron can be given parenterally in the form of ferric gluconate, iron dextran, iron sucrose, ferric carboxymaltose, and ferromoxetol. Comparison between agents reveals similar efficacy with differences in cost analysis from diverse administration schedules. Iron dextran and ferric carboxymaltose are U.S. Food and Drug Administration approved for the treatment of iron deficiency when oral supplementation is impossible or ineffective. All parenteral iron products can be administered undiluted slowly as an intravenous push, or diluted and administered by infusion. Although not included in the FDA-approved labeling, iron dextran injection is commonly diluted in 500 ml of 0.9% sodium chloride and administered by IV infusion. Iron dextran is also the only product that may be given intramuscularly. This route may be preferred in a few instances, such as in patients with limited IV access. Although the data are limited, infusion of the total dose, total estimated iron deficit, of iron dextran is given in clinical practice and has proved to be effective and convenient. The total dose method of administration can be associated with a higher prevalence of fever, malaise, flushing, and myalgias. Because of the potential for anaphylaxis with iron dextran, an IM or IV test dose should be given. The test dose for adults is 25 mg of iron dextran. Although anaphylactic reactions usually are evident within a few minutes if they occur, it is recommended that a period of 1 hour or longer elapse before the remaining portion of the initial dose be given. Subsequent use of test doses should be considered during iron dextran therapy, but is not required. Ferric gluconate, iron sucrose, and ferromoxetol are parenteral iron formulations that are FDA approved for the treatment of iron deficiency anemia in patients with chronic kidney disease undergoing chronic hemodialysis. Ferric carboxymaltose is indicated for treatment of iron deficiency anemia in non-dialysis-dependent chronic kidney disease. A test dose is not required for these agents due to the lower incidence of serious anaphylactoid reactions. Iron requirements in these patients typically exceed 1 to 2 grams and, therefore, multiple doses of ferric gluconate and iron sucrose are needed to achieve the total dose of iron. In general, rates of adverse effects are similar among agents. Patients should be monitored for hypersensitivity reactions for at least 30 minutes after administration of any parenteral iron compound. The next question reads, what is the total dose of iron dextran for IV infusion that would be needed to achieve a normal HGB value for BHP and to replenish her iron stores? How quickly should she respond? The total dose of iron dextran to be administered can be determined using the following equation. Iron, in milligrams, is equal to patient's weight, in pounds multiplied by 0.3 multiplied by 100 minus opening brackets 100 times hemoglobin level, all divided by 14.8 closed brackets. Where hemoglobin refers to the patient's measured hemoglobin in grams per deciliter. The equation uses the person's weight, in pounds, and assumes that a hemoglobin of 14.8 grams per deciliter is 100% of normal. Children weighing less than 30 pounds should be given 80% of the calculated dose because the normal mean hemoglobin in this population is lower. For patients with anemia resulting from blood loss, e.g., hemorrhagic diathesis, or patients receiving chronic dialysis, the iron requirement is based on the estimate of iron contained in the blood lost. In this case, the following equation should be used. Iron, in milligrams, is equal to blood loss in milliliters multiplied by the hematocrit, that is the patient's measured hematocrit expressed as a decimal fraction. This formula assumes that 1 milliliter of normochromic blood contains 1 milligram of iron. After parenteral administration, iron dextran is cleared by the reticuloendothelial cells and processed. The iron is then released back into the plasma and bone marrow. Because the rate of iron incorporation into hemoglobin does not exceed that achieved by oral iron therapy, the response time is similar to that of oral iron therapy, and the HGB can be expected to increase at a rate of 1 to 2 gram per deciliter per week during the first 2 weeks and by 0.7 to 1 gram per deciliter per week thereafter until normal values are attained. The last question reads, what side effects can be expected from parenteral iron therapy? Overall adverse reactions reported with parenteral iron administration are rare. Anaphylactoid reactions occur in less than 1% of patients treated with parenteral iron therapy and are more commonly associated with iron dextran and ferrum oxetol than with ferric gluconate and iron sucrose. In a small study comparing iron dextran to ferric carboxymaltose, patients experienced significantly fewer immune-related adverse reactions. Other side effects seen with parenteral iron agents include chest pain, headache, hypotension, nausea and vomiting, cramps, and diarrhea. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 501.